Hello and welcome to Pediatric Procedural Sedation, how to use evidence-based medicine to support practice change. I'm Corrie Chumpitazi, Associate Professor of Pediatric Emergency Medicine at Texas Children's Baylor College of Medicine, and I'm delighted to be joined today by Michael Mallory, who is the Chief of Medicine and Medical Director of Operations at Scottish Rite Hospital, Children's Healthcare of Atlanta, and Mark Roback, who is the Section Head of Emergency Medicine at Children's Hospital, Colorado. We have no disclosures, and we are going to talk about the off-label use of our medications for sedation that aren't labeled in children. Our learning objectives for today are to describe the importance of evidence-based unscheduled sedation guidelines, to understand pre-procedural fasting, the myths and the facts, and then to delineate key steps in building a sedation service for appropriate reimbursement. Challenges in everyday practice. We all practice in busy emergency departments, and we see ill and injured children every day. Our patients requiring sedation are not often the most critically ill patients in our department, but they require additional resources. We know that pain and anxiety are undermanaged in children compared to their adult counterparts, and it's no longer appropriate just to hold children down with butane for procedures. So our goal really is to improve patient care and experience for the children who require procedural sedation. So we know that sedation outside the OR is rapidly increasing. When we look at cases across the ED, we know that elective procedural sedations happen in a variety of settings, from the hem-onc clinic to the GI procedure suite and elsewhere. These are performed by a combination of practitioners, including anesthesia, critical care, and nurse advanced practitioners and others. And then we have over 2,500 sedations in the ED. We think that's an underestimation performed annually, but that's our best guess from published data. And the majority of these are taken care of in the community general ED. When we look at our large institution anesthesiologist services at big children's hospitals, we know that even a third of our anesthesiology cases are outside the operating room. And so they're provided, once again, by a wide variety of providers. When we look at the Pediatric Sedation Research Consortium, which is made up of multidisciplinary providers, we see that blue group, a lot of those sedations outside the ED are provided by critical care medicine, as well as the gray proportion of EM, followed by the anesthesiologists and a variety of other practitioners, including a growing hospitalist service. And these are a variety of procedures. So we have had sedations for a large proportion of radiology studies, both in MRI, CAT scan, as well as nuclear medicine and interventional radiology, for the oncology procedures, for GI procedures, as well as a variety of other procedures. From an ED standpoint, the largest procedures that are receive sedation are our fracture reductions, our incision and drainage, and our laceration repair, which makes up about 30% each of those categories, and then a smattering of other things, including burn and derm debridement, foreign body removal, exam under anesthesia, and such. Imaging makes up a small proportion of sedations in our DED, but when we were able to look across the country and see what medications folks are using, sedations performed by the multidisciplinary group through the Pediatric Sedation Research Consortium, propofol was an extremely well-utilized medication, as well as the classics midazolam and fentanyl, with increasing dexmedetomidine use, and thankfully chloral hydrate has been going away. So a wide variety of medications. When we looked at the sedations that were done by the Pediatric Emergency Medicine North American chiefs, they reported medication use by using 100% of the departments used ketamine, midazolam, and fentanyl. Etomidate was highly utilized, and propofol was used in 76%. Dexmedetomidine, as we said, was about 60%, and similarly, nitrous oxide was used by 60% of departments, mainly by freestanding machines rather than piped in gas. We also learned through that evaluation that 85% incorrectly categorized ketamine as moderate sedation. We're going to get into that dissociative definition, but we did see some really good things. We saw end tidal use used by many, as well as we did see in that larger group that many people are asked to sedate for radiologic procedures. When we look at sedation guidelines, we know that one dose, one drug in one patient may not equal a single effect, but we are tasked with trying to create guidelines that keep children safe and provide a guide. And so this is just one example of those guidelines that are available online. But I think it's really important to talk about those guidelines. So to help us with that, I'm going to go ahead and turn that over to Dr. Roback, and he's going to get into the data on that.
Thank you, Corey. This first slide is just some examples of guidelines that have been published in the past, or you can go through those. The American Society of Anesthesiology and the American College of Emergency Physicians have been writing these guidelines for the past 4 years. And you can see these have old-fashioned terminology like conscious sedation, referring to non-anesthesiologists, which really is not a good descriptor of what we do as emergency physicians. And I think the next one is an ACEP guideline that we wrote about ketamine, which is now almost a decade old. The next slide will emphasize that in 2016, the American Academy of Pediatrics came out with their guidelines for procedural sedation that were written by an anesthesiologist on campus. We've struggled with AAP to get input from emergency physicians, but have not been very successful. In 2018, ASA came out with their guidelines for moderate procedural sedation, and you can see there's a group that support this. ASAP is not part of that group. When ASA approached ASAP had lots of feedback, which ASA was not very interested in, and so ASAP declined to be part of that. This led to an editorial that Steve Green and Luke Krauss and I wrote about that particular ASA document, which does not really recognize the fact that emergency physicians are fully qualified by training to administer all levels of sedation. Emergency medicine has been at the forefront of sedation research and safe practice for decades, and that we don't think that we should allow non-evidence-based efforts by other specialties to dictate how we administer sedation for our emergency patients. And that led to our publishing the unscheduled procedural sedation guidelines to ASAP. The ASA document tried to redefine the protocol of ketamine and accommodate as it is intended for general anesthesia, which we found to be distressing. So the unscheduled procedural sedation guidelines were written with support from ASAP. And really, in this document, I think that we outlined that all sedation states are covered, and that medications need to be considered as to what depth of sedation they achieve to be different depending on the dose of medicine administered, and the ketamine was different. It does not result in the usual sedation continuum of mild, moderate, deep, really social sedation, which is defined here and has been like this since the first came into use in the 1960s. The other thing about the unscheduled sedation guidelines that I think are important for us is that the Centers for Medicare and Medicaid Services have acknowledged that emergency medicine training and practice is unique, and that we are perfectly able to provide any depth of sedation for our patients, that we have the skill set needed to rescue needed, and that we are qualified to provide all of this sedation. And this is something that I think is really important as we talk about regulatory restrictions and what the individual hospital may or may not do regarding sedation. And so one of the strongest recommendations that I can make, please go to this one, Corey. Yes, is to be a part of the process at your hospital. We have CNS and us, sedation literature to support us, and I've been on sedation committees for 25 years now. I think it's really instrumental in we having voice into how policies and procedures are written and regarding how the practice is not in the Corey is also a member of the sedation community at Texas Children's Hospital, and I think we've both been pretty fortunate to have found partners with anesthesiologists with whom we can collaborate to write policies that make sense for our practice and our patients. So I strongly recommend that you have our representative in your hospital sedation committee, develop a coalition of other emergency and critical care providers who all have the same skill set for providing sedation, and in accordance with CMS, when anesthesia when needed for anesthesia. The next thing I wanted to talk about is a subject that can be quite contentious in some institutions regarding pre-procedural fasting, and which patients who are going to receive emergency procedural sedation are appropriate to do so.
Sorry.
So we all are familiar with the ASA NPO guidelines for elective procedures, the 246, and hours of NPO status prior to the time when we can administer sedation. This is for elective procedures, not for emergency procedures, and it is important to acknowledge that these numbers came from consensus panel opinions, absolutely not consensus panels, but I have to say that there is no literature to support that all of these guidelines changes out from the stage. And so ASAP has, we'll go just back a second. Yeah, ASAP has really come out and said that delaying procedural sedation to meet guidelines such as this does not change outcomes and practice that we should follow. What we should do is assess the risks and benefits for each patient and determine whether the urgency of the procedure dictates providing sedation without delay regardless of the classical status. Not all of the literature behind all as we go forward. This is a combination of several studies and looking at risk and aspiration. Certainly, procedure fasting status is designed, and regulations and guidelines are designed to prevent pulmonary aspiration. Well, we know that pulmonary aspiration during anesthesia is uncommon, about 3 in 10,000. And if you look at the rate in procedural sedation of adults and children, it's really less than 1 in 10,000. And of those who do experience pulmonary aspiration, there are risk factors attributed to this outcome. And number one is planned air manipulation. The greatest risk is that putting too in and too out. Absence of air protective reflexes. Patients who are having a disease which is low and minor, so it's a class rating. And then, of course, extremes of age, less than 70 years, all have a greater risk for inspiration. What is the evidence? Steve Green and colleagues published this review in 2017 in the British Journal of Anesthesia that reviewed all aspiration cases from 1985 and 2016, and 90% of these cases occurred during endoscopy. This is with procedural sedation and sedation. And in the pediatric population, the rates are much lower and also related to specific procedures. That was uncommon in cases in adults, and those were all patients with severe underlying disease, and no deaths in the pediatric. In 2016, the Society for Pediatric Sedation published this 140,000 sedation. This is a record, mostly record sedation, but they only had 10 cases of aspiration, and of those, 10 had been fasted according to the ASA guidelines. And so this really emphasizes that following ASA guidelines for NPO status was not protected in these cases. And they also recognize risk factors, young age, procedure like bronchoscopy, obstructive sleep apnea, and high ASA. And the next study is was performed by Roback and her multi-centered group of pediatric emergency research Canada. We enrolled over 6,000 patients in the safety surveillance looking at adverse events. This slide shows you typical pediatric sedation, mostly acute reduction and cardiac respiration repair. And ketamine is the most commonly used drug and the patients who are fasted and those who are not fasted are really not different. And so we were not following of ASA. It should be, since this is emergency sedation. These graphs show you fasting duration on the x-axis in hours, and then various adverse events or interventions on the y-axis. And you can see that as you go out in duration, the risk for adverse events or significant interventions do not change with the length of time you go. And so what this says to me is that if you wait amount of time to meet the guideline, you're not changing outcomes. So waiting in the patient period to whatever hours you want to make up doesn't change outcomes as a practice. So from these studies, I think we can conclude that adherence to fasting guidelines is highly variable. There's never been a aspiration of a child. Reported. There have really been several of these prospective cohorts have now shown this association between fasting duration and adverse events. And so, as we think about what we do for procedural sedation for emergency patients, really it's more about the patient risk factors, the type of procedures that are performed, endoscopy, bronchoscopy, that place patients at risk. So the typical short duration, relatively healthy patient in the emergency department, the risk is exceedingly low. And pediatric sedation, ketamine is run or airway reflexes and so what is the downside to following these NPO guidelines? In pediatrics, delaying developing NPO time can lead to hypoglycemia in young children. It also shows that children who are fasting longer are irritable and are covered in state. And it's also a delayed glucose, which we see is priority. And the biggest reason is that strict adherence to guidelines is essential. And so our fasting recommendations then I was creating unscheduled sedation guidelines for ASAP. Really say it's important to assess timing and duration of the reasonable intake. We should consider the necessity of a procedure and then recognize the patient factors that exist to really their increasing risk. And the way is not feasible, consider the use of ketamine as but again, it's not recommended for any serious solution to the
Fantastic. Well, thank you, Dr. Roback, for that summary of the guidelines and for getting us to the state of emergency sedation today. I think that debunking the fasting guidelines, that was a fantastic review. And so now, what is the role for our audience as an EM provider? How might they think about what exactly do our patients need? Can they consider do they need just analgesia or sedation or both? And then is our patients appropriate for sedation? Are they the appropriate ASA status, as we just covered? What is the body habitus? As obesity increases those risks? And what are their other airway risks? Are there extremes of age that we should consider? And then what are those procedure factors? Are they supine or are they prone? How long do we need to be sedated for? So all of those items we'll cover in just a bit. When we look at those sedative factors, might we need just the hypnotic to help with promoting the drowsiness and sleep? Or do we need some anxiolysis to relieve apprehension and the fear due to that event? Do we want them to disrupt their memory? Do we want the amnestic effect to help with that as well? And do we need to relieve some pain? Most of the procedures we perform in the emergency department are painful, and so we need medications that can help with that. When we look at that potentially difficult airways, we need to think about what are their congenital malformations that may lead to increased risk. Do they have a large tongue and make their airway more problematic? Do they have a small jaw or limited elanoaxial mobility? Do they have any kind of hemangiomas or abscesses or locations that may be leading to compromise? Or do they have tonsillar hypertrophy? Are they snorers and suffer from those types of items? When we look at overall adverse events, a series done by the Pediatric Sedation Research Consortium has an overall total adverse event rates for sedation outside the OR of about 3.4%. When we compare that to the large pediatric sedation studies, we see that the elective sedation done by the PSRC, as well as looking at ASA status, where they had a larger proportion of more critical patients, ASA grades 3 and 4, with longer procedures, with largely propofol, versus our emergent sedations, which were largely 1 and 2 classification ASA status, painful and shorter procedures, as well as a larger ketamine use. Our apnea and laryngospasm rate was about that 1%. We had no aspirations in our cohort, and then no deaths in that study that Dr. Roback mentioned from Dr. Bott out of Canada, and 0 intubations. So obesity is problematic. We do see that as the obese patients in that database did show that there's an increased odds ratio of any airway intervention. So jaw thrust, nasopharyngeal airway, oral airway placement, bag valve mask ventilation, as well as repositioning and suctioning were all significant in the patients that were defined as obese. What do we think about upper airway infection? What's a little runny nose? Most of our children, after they have IV placed for their sedations, have a little bit of a runny nose from the tears and those kind of things. How much URI is too much? We looked at Dr. Mallory and colleagues in the pediatric Research Sedation Consortium looked at that as well in patients that were defined as the black box here as recent URI, the gray boxes as current clear URI, and the green boxes as current thick URI. You see as we move across those more severe definitions and potentially symptomatic URIs, that they did have increased risk for those airway interventions as well, suctioning, nasal airway placement, bag valve mask, and so forth. So thinking about those procedures and taking that into account and the acuity of the procedures that need to be done in the emergency center. That's not saying don't sedate those, but thinking about those risk factors and those needs for more likely interventions. And then similarly, as far as the adverse events go, correlates as well with increased risk of wheezing, stridor, apnea, and any airway adverse event as that thicker URI proceeds in severity. When you think about your setting, you might want to think about your referral algorithm, where you're sedating, who your backup is, what kind of risks do they have, and then thinking about having a standardized approach to who requires referral is always a good idea. We're going to move on to Dr. Mallory and talk about his thoughts on building a sedation service and sedation as a business plan. So Dr. Mallory, I'll turn it over to you.
My name is Michael Mallory. I'm a pediatric emergency medicine physician and sedation physician in Atlanta, Georgia. I work at Children's Healthcare of Atlanta with Pediatric Emergency Medicine Associates, which have a wholly owned subsidiary called Pediatric Sedation Services, where we have a high volume sedation service. I'm going to talk with you a little bit about sedation business plans, the end section here, and it's going to be a summary. First, I want to talk a little bit about what you need to do in terms of building a plan and then how you can implement it and hope to make it work both for your personnel, your faculty, your sedation physicians, providers, and also from a financial standpoint, make it viable and useful for your institution. So first, you do need to define the service. You need to define what you are planning to do. You need to do a market analysis to see how much need is there for what you can provide, and then develop an operating plan, which includes your staffing, your scope, the support you'll need, both personnel, space, equipment, and possibly financial to get started. Also need to look at your financial benefit. The financial benefit can be looked at in a number of different ways. One, you can look at it as a benefit to the institution in terms of actually generating revenue. If you have a high enough volume and are billing well and are reimbursed well, this can be a revenue generating endeavor. Second, it can reduce the need for more expensive providers, specifically anesthesiologists. If you are a non-anesthesiologist, an emergency medicine physician perhaps, or critical care, or even hospitalists now are doing this, or need nurse practitioners, then you may be a bargain for the institution in terms of providing sedation without having to pay quite as much for the provider. Likewise, there are sort of downstream revenue benefits, such as improved efficiency and improved throughput. We'll talk about these. You need to be able to do some marketing, make sure that people know you're out there, and eventually look at your growth potential and see long-term, is this something that's viable? And then finally, it's put here finally, honestly, a lot of times it starts with this. Do you have buy-in from stakeholders? I know in our own service, we came and were actually approached by the hospital. We said, look, anesthesia doesn't want to do this, and critical care doesn't want to do this. Will you guys be interested in doing this? So we were sort of approached and had buy-in from a number of our stakeholders, most notably our radiologists, but also our anesthesia team, our critical care team, our oncology team. We had a number of folks come to us and really want us to do this. So market analysis, what are the benefits to patients? And in this instance, I think a lot of times you can look at the 6 domains of quality. How can you provide timely, efficient, effective, high quality care, safe care to your patients and help them obtain the diagnostic procedures, but sometimes the therapy as well that is needed to fill their needs in an efficient manner. You need to look at the procedures, the locations, and the providers. This can range from a emergency department in a large freestanding hospital to a radiology department to a oncology department, interventional radiology, and indeed we even staff a off-site, meaning freestanding smaller center that's an imaging center for the hospital where we sedate for MRI procedures there. So there are various different procedures, from painful procedures in the emergency department or oncology center to non-painful in radiology. You need to consider these, and then also consider your providers. Who's going to staff this? Is this the moonlighting gig, or is this a full-on service that you are planning to build? Look at your projected volumes, make sure that you have the need. Consider the benefits to consulting providers. And again, the consulting providers, again, these are in some regards your customers. These are the radiologists, the oncologists, the emergency medicine doctors who are asking for your services in sedation, sometimes gastroenterologists. These are the people who are saying, hey, yeah, actually, I could use your services here. You want to look at your payer mix. Again, this is looking at finances. And just from a reimbursement standpoint to see, is this going to be a viable enterprise? You could have relatively good volume, but your payer mix is something to consider. Just realizing that, if we're talking about the business side of things, this is not necessarily a factor that would determine whether you go into this or not. I think that the factors that are most important are really your patients and your consulting providers, but it's something to consider for certain. And then your facility characteristics. Do you have the space to do this? Is there a sedation unit? We have a sedation unit at our MRI area in radiology at Children's Healthcare of Atlanta at Scotch Wright. What kind of equipment are you going to need? And when I say flow limitations, I'm talking, are you only able to see 1 or 2 patients at a time, or do you have a 16-bay sedation unit where patients can come in and you can get them worked up and queued up to get going? I'm going to look at and probably assess and argue for, if they exist, for the benefits to the institution. Does this redistribute the workload? Does it make it more efficient? If there's a backlog of studies needing to be performed or facilitated by an anesthesiologist, but we only have so many anesthesiologists, does this help? Does it reduce costs in that way and possibly improve efficiency? And then your growth potential, again, ultimately, is this something that's sustainable? Is it something that you could start small and grow? Or what exactly will you need to do in the long term to plan for growth if it's going to work? The financial benefit, we alluded to this before, your reimbursement and your payer mix. These are 2 things, but they are tied together. And depending on how what your setup is. If you're working in an academic institution, then you may have this taken care of with contracting, but there are different ways of doing it. And we can talk about this in a little bit in terms of how you actually bill and how you'll get paid. Again, depends frequently on your contracting success and your payer mix. Does this provide cost savings to the institution? Is this the kind of thing that the institution is going to say, hey, we're able to actually reduce our overhead because we, instead of paying for a more expensive provider, are able to pay for a less expensive provider. And then also the efficiency for MRI and other services. And I call this a margin generator. If you are able to make the MRI work more efficiently, then that is something that helps generate margin for the institution. In a lot of institutions anyway, MRI is a margin generator and is something that's a very expensive and valuable asset. And if we can keep it working efficiently, then that helps the institution and helps our patients. And then finally, coding matters. There are anesthesia codes and there are moderate sedation codes. I'm sure that as emergency physicians, and I expect that's what we all are, most of us here listening to this, moderate sedation codes are pretty common. This is when you are providing the sedation for a patient that you are also performing a procedure on. Then you cannot bill anesthesia codes. You must bill a moderate sedation code. But anesthesia codes typically are reimbursed at a much higher rate and helps your economic viability. So there are monitored anesthesia care, or MAC, which really does not describe the continuum of depth of sedation. Monitored anesthesia care, MAC, you could provide nothing, but you have to be available and ready to provide general anesthesia. So it's the need for deeper levels of analgesia and sedation that can be then can be provided by moderate sedation. So this is the ability to go to general anesthesia. What we bill where we are is anesthesia codes. These are linked. They're links to the CPT code. It's an ASA bridge code. And what typically happens is you have a CPT code for a specific procedure, and then you have an ASA bridge code, which is specific to that procedure, down to the point where, like I think if you've got an abscess on a leg versus an abscess on the trunk, there's a different code and a different bridge code for the deep sedation that you would provide. And this is what we do in our location. In these instances, as with MAC, the sedation provider cannot be involved in the procedure. You're providing sedation only, and you document your pre-anesthesia assessment, you document vitals during the procedure, and then you document your recovery and the post-anesthesia care that's there. So there are different requirements, and this is not something that you can do while you are performing the procedure. So giving ketamine and working on an abscess on the same patient for your patient is not how this would work. In our instance, we have a sedation service that will be consulted for an abscess drainage or a fracture reduction in the emergency department, and we will come and provide sedation, and that allows us to, on the sedation service side, simply provide great sedation, or at times, if we're honest, if we define general anesthesia as being able to undergo a painful procedure without movement or response to pain, it is at times at least brief general anesthesia for a patient. And I think that's what we prefer. If you've got a child who's got a broken arm, you don't want them whining and crying and writhing. It's not good for your child. It's not good for the provider who's trying to reduce the fracture or drain the abscess. But we've got a person who is simply dedicated to providing the deep sedation. And this provider has to document their own pre-anesthesia assessment and vitals monitoring, post-anesthesia care. So operations plan, I personally think it's wise, and we have our own quality database. This helps us immensely for OPPE and FPPE because we can simply pull up the database, pull up a specific provider's numbers, their outcomes, the procedures that they've sedated for, and we can look at the interventions they performed. We can look at the outcomes or adverse events, or events, as I would say. I call these more sedation events. Some of them are adverse, but when a patient goes briefly apneic or goes apneic for a full 20 seconds, which was of course our definition of apnea, but they don't actually become hypoxic. Is it adverse? I don't think so. It is a sedation event, but I think it needs to be recorded. And I think that from a quality standpoint, it's just responsible to collect all this. And then, of course, I believe also that benchmarking this, and we are participants in the Pediatric Sedation Research Consortium, which is the sort of research and outcomes arm of the Society for Pediatric Sedation. This is a fabulous database of hundreds of thousands of kids at this point. And it's a way to take a look at yourself versus your peers and see how are you doing. There are also compliance issues. You need to have a quality program. And again, as we talked about, I think having these things in place are just basic There are Joint Commission and CMS regulations regarding sedation, the timing of signing notes and the assessments. You have to assess your outcomes. There are, of course, the usual HIPAA coding and billing compliance. And you need to have a compliance officer and describe your review process for your compliance, unless this is taken care of by you for your institution. So in summary, your mission and goals really are the essentials of the service. You need to find out who you're serving, and that is frequently, the more people, the better. But obviously you're serving your patients, you're serving their subspecialists who consult you, be that in the emergency department or elsewhere, and in the institution. You look at the market drivers, discuss with your stakeholders, and assess your potential for growth. Develop a marketing plan, because when you first start something small like this, you're really going to have to build relationships and help people understand the value that you can bring. Organize your team structure, and not on here, but also very important, make sure that your process is sound for delivering and measuring quality. Be able to summarize your operations succinctly, and make sure that the financials of your service are sound, and that the value of your service is understood and well established.
Thank you, Dr. Mallory. So in summary, we want you to get involved with your sedation committee. This is the way we can provide quality pediatric sedation care to all children. Use the ASAP unscheduled sedation guidelines, as it does apply more to our emergency practice. And then do not delay emergency sedation due to fasting times alone. You must assess the benefits and risks, the urgency of the procedure, as that will dictate timing, and regardless of fasting status. If it's an emergent procedure, it's going to proceed regardless. And then utilize the principles for establishing a sedation business plan so that you can maximize your sedation service as well. We thank you for your time this afternoon, and please feel free to reach out for us. And thank you, SAEM 20.